And good morning, everyone. Thank you for joining us today. I hope you had a great summer. Today's webinar is entitled Treating Trauma to Achieve Recovery. And before we get started, I think it's important to take a moment to reflect on trauma today. So we've all experienced trauma in different ways, both personally and collectively. And as we come together today for this webinar, reflect on one of our greatest shared traumas, which is the events of September 11th that happened 24 years ago today. It's hard to believe. And so we honor the lives lost and the first responders and the families and the communities that were impacted and anyone who's impacted today. And I know that day left a lasting impression of trauma on me, and I'm sure so many of you as we experience that collective trauma together so deeply, and not just on that day, but for many months and many years after. So today we focus on understanding trauma and its connection to mental health, substance use, and recovery. And together with our expert panelists, we'll explore how to address trauma with compassion and effective strategies so we can support healing and support resilience. And so thank you for being here with us today for this webinar and for being part of this important conversation. And so now we have some housekeeping before we get started. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJ OEMS for one EMT elective CEU. And the Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers. And this program is eligible for one maximum Category 1A hour credit, or CEU. PA Planner Dean Barone discloses that he serves on the Speakers Bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose today, and all relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that, we'll no longer be able to issue you credit. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative Community Responses, and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to have today's expert faculty. I think the information they're going to share with us is so significant. We have Dr. Roxanne Jeffries Baxter. Dr. Baxter is the founder of Branch Behavioral Health Services in Pittsburgh, Pennsylvania, and is a board certified psychiatric nurse practitioner with more than 20 years of mental health experience. And Morgan Thompson, a good friend to our organization. Morgan is a person in long-term recovery and the CEO of Prevention Links, a nonprofit organization focused on preventing the development of substance use disorder and supporting individuals in their recovery journey across the lifespan. And so I thank both of our expert panelists for being with us today. Looking forward to your comments. And Dr. Jeffries, I'm going to turn the presentation over to you.
Okay, thank you so much. As previously mentioned, hello everyone. My name is Dr. Jeffries. I am a psychiatric nurse practitioner, as well as educator and researcher. And I wanted to thank the staff over at Partnership for Drug-Free New Jersey for allowing me the opportunity to speak about something that I am so passionate about. So we conducted a study back in 2023 as part of my DMP project, and the study was entitled The Influence of Trauma History on Opiate Use Disorder in an Urban Treatment Center in Pennsylvania. Slide. The origin of this problem emerged from a clinical observation I made while working as a nurse practitioner in a methadone clinic in Pennsylvania, where I observed that clients with OUD consistently presented with higher trauma scores and demonstrated poor outcomes when compared to those with other SUD diagnoses. This observation raised critical questions for me about the role of trauma history in shaping OUD treatment outcomes. Motivated by this problem, I entered graduate school with the intent on investigating the influence of trauma on opiate use disorder. Develop evidence-based, culturally appropriate, trauma-informed approaches. Slide. Okay. So let's just go through some definitions. Trauma. There are two working definitions that we use professionally. One is an overarching definition from SAMHSA 2024, which defines trauma as broadly defined as an experience or event that overwhelms an individual's ability to cope, threatens their sense of safety, and results in lasting adverse effects on physical, emotional, social, or spiritual well-being. In this context, trauma can be physical, psychological, or collective, shared by groups or communities, and its impact is shaped by both the event and the individual's responses as well. There's also a clinical definition of trauma from APA 2023 and 2022, where trauma is defined in the context of meeting PTSD, post-traumatic stress disorder, diagnostic criteria, with the first one being exposed to an actual or threatened death, serious injury, or sexual violence. This exposure can occur by either directly experiencing the event, witnessing the event, learning about the event from a close family member or friend, or also, in our case, as healthcare workers, repeated exposure to details of traumatic events. Trauma can also be categorized in three groups. The first is adverse childhood experiences. The second is potentially trauma events. And the third is the DSM-5 diagnosis of post-traumatic stress disorder. Adverse childhood events are early life traumas or stressful events. For example, abuse, neglect, household dysfunction, and these things that happen early in life increase the vulnerability to PTSD, substance use disorder, and mental health disorders. The tools that we use to measure these ACEs are the Childhood Experiences Questionnaire by Finetti et al. 1998. And then moving on to potentially trauma events. These are broad exposures that may or may not lead to post-traumatic stress disorder. Example of these traumas in this category includes exposure to natural disasters, accidents, combat, or interpersonal violence. And to assess these types of trauma, we use the LAC-5 by Weathers in 2023. We've already discussed the DSM-5 diagnosis of post-traumatic stress, but to assess this condition, we use a different tool called the LAC-5. And to meet diagnostic criteria for this disorder, people have to have symptoms in 4 clusters: intrusion, avoidance, cognition and mood, arousal and reactivity. And all of this should happen after a trauma exposure. Slide. Another definition we need to clarify is the definition of opiate use disorder. I've noted 3 definitions here. The first one is from the DSM-5, 2013 and 2022, where OUD is defined as a problematic pattern of opiate use leading to clinically significant impairment or distress as manifested by at least 2 of 11 criteria within a 12-month period. Examples of the criteria include craving, tolerance, withdrawal, unsuccessful efforts to cut down, continued use despite harm. There are also modifiers based on symptom level: mild, moderate, and severe. Then we have NANDA and NIH from 2023 that defines opiate use disorder as a chronic relapsing disorder characterized by compulsive opiate seeking use despite harmful consequences that is accompanied by long-lasting brain changes. And then ASAM from 2020 defines OUD as a chronic medical treatable disease involving brain circuits, genetics, environmental, as well as environmental and life experiences, marked by impaired control, cravings, tolerance, and withdrawal. Okay, slide. So let's talk about why trauma increases the risk for OUD. So over on the left, in the red box, we have a traumatic event, either childhood, potentially trauma experience, or PTSD. And what these occurrences do is they cause neurobiological changes, either to the hypothalamic pituitary axis, the stress reward circuitry. Changes in these areas in the brain can lead to what we call trauma symptoms that involve emotional dysregulation, anxiety, intrusive memory, poor sleep, all of those trauma symptoms that we see um, can occur. When these trauma symptoms occur, a person may choose to self-medicate with substances. One of them would be opioids. Um, And we know that continued use places that person at risk for opiate use disorder. And what I did over on the right side of the slide is I pulled out the bottom three um, topics to show how things are a little bit different with opiate use disorder. With the opiate use disorder, in the bottom orange box, you see there's symptoms of emotional dysregulation, followed by above it, the blue box, uh, where they may self-medicate to help ease these symptoms. And then followed by a relapse, opiate use relapse, if they're already in treatment for opiate use disorder. And after the relapse, the green box below it shows withdrawal symptoms, which can in turn what I meant to say was that withdrawal symptoms can mimic um, trauma symptoms of emotional dysregulation, hyperarousal, body sensation, and sleep changes. And if this person, while experiencing these withdrawal symptoms, have what we call a trauma trigger and have superimposed trauma symptoms on top of that, they may decide to self-medicate with opioids and have a relapse. And so you see this is a cyclical uh, occurrence where one symptoms feeds into the other. And the higher the trauma score, the more severe and intense the trauma symptoms can be. Next slide. So back to the study. The influence of trauma history on opiate use disorder in an urban treatment center facility in Pennsylvania. We did a background search, and what we found was, of course, we're having an opioid crisis since 2018, I believe, or 2017. But as more recently as 2023, there were more than 100,000 opioid overdose deaths in the US. And the background search also revealed, in terms of trauma, that trauma is a pretty common offense, that worldwide, at least every person reports 70%, I'm sorry, not every person, 70% of the population reported at least one traumatic event. And of that number, 30% reported four or more traumatic events. And so, what is the intersection of trauma and PTSD? Is that they're comorbid, that people with SUD have a high prevalence of trauma and PTSD. So to go into that fact a little bit more deeper, we have some studies that show that 25 to 50% of individuals with SUD meet criteria for PTSD. And these studies focused early on substances like alcohol, stimulants, and there was very limited data on OUD. However, more recently, 2023, 2020, and 2020, um, there have been reviews that show the lifetime prevalence of PTSD in OUD population as high as 41%. Current PTSD, 41%, with OUD being the highest across the SUD categories. So what this showed us in the literature review that the gap was, despite high prevalence estimates, comparative research on trauma severity between OUD and other SUD population remains limited. Slide. So the purpose of the study was to examine the influence of trauma events on the development of OUD. We already talked about that. And the hope was that this study would provide foundational work for future interventional studies involving trauma and OUD. So what we did with the study was that the first aim was to describe the demographic characteristics of OUD and SUD participants. The second aim was to examine the association between PTEs and PTSD diagnoses of people diagnosed with OUD and SUD, the study participants. And the third aim was to examine the number of PTE occurrences in both study groups. Slide. We did use a theoretical framework, Cassian, 1997. He formulated the self-medication hypothesis. Even though hypothesis is in the title, it is a tested theory. And what the theory states is that people with substances may self-medicate to manage emotional dysregulation and distressing symptoms. And what we did for the study was we adapted the study to fit our concepts. So you see the first concept, the individual, was where we looked at the demographic variables, and the second concept was where we looked at the trauma exposures, and the trauma exposures that we were focused on in the study was the PTEs and post-traumatic stress. And then the third concept, we looked at substance use disorder in two groups, primarily focused on opiate use disorder, but using the broad category of SUD as a comparison group. Slide. The methods, it was a retrospective chart review with N equals 150, two groups of 75, OUD and SUD. We already talked about the setting. And the measures that we used three. We used the investigator-made demographic survey to assess gender, age, race, and ethnicity, as well as the LEC tool to measure PTEs, and then to measure the diagnosis of PTSD, OUD, and SUD. We just obtained those diagnoses from the medical record. Slide. So results in those three areas. Slide again. In the demographics area, you see we have three columns. We have the characteristics and then the OUD group and the SUD group. The mean age in the OUD group was 37 years, SUD was 47. In the OUD group, the gender was 51% female, whereas 41% in the SUD group. In the OUD group, 73% of the sample was Caucasian or white, whereas in the SUD group, the same race was 43%. And among the OUD group, African Americans were 21%, while the SUD group was 55%. Slide. So the next measure we use to measure the actual trauma occurrence. And the literature supports that trauma is fairly common. 70% of the population has one trauma. And so if you look at 4 and below, you see the numbers between both groups We're just about the same. But when you get above 5, you'll start to see differences, especially in the OUD group in comparison to the SUD group. As far as the PTSD diagnosis, in the OUD group, what we found on the chart review was that 18.7% were diagnosed with PTSD, whereas 10.5% were diagnosed with PTSD in the SUD group. You see there was a slightly higher percentage in the OUD group. So key findings. The key finding from this study was, did we answer the research question? And the answer was yes, we did. We found that participants with a higher trauma score, notably of a five, were more likely to develop opiate use disorder, chi-square 5.7, p equals 0.23. And this supports the link between trauma, burden, and OUD risk, at least in that facility. But we also found some racial disparities. We noted that the participants in the study um, were 21% African American compared to the community demographic of African Americans of 69%. Which suggests maybe disparities in the referral process, treatment access, or legal involvement. We're not sure. But we did have an unexpected finding, and that was that there was no significant difference between PTSD rates between OUD and SUD groups. And one possible reason for that is that there may have been underreporting, small sample size, or limitations from paper recording of the medical record. Next slide. And so study limitations, we talked about this a little, I did on the last slide, that the design was retrospective, so it limits causal interpretation. It was a convenient sample from a single site, so that limits generalizability. And then the reliance on paper records may have led to underreporting and possible errors. Next slide. So future implications, of course, a larger sample size, maybe multi-site studies to improve generalizability. In order to address the disparities, we need to continue to document and investigate the reasons for potential sources of the disparity in OUD and SUD treatment, and also as a future study to examine the intersection of trauma race and OUD and SUD populations. And finally, we need interventional studies to test whether culturally competent trauma-informed models improve OUD treatment outcomes. Next slide. So this next part goes into clinical practice. How do we use this information in practice? So I wanted to differentiate, I'm sure most of you probably already know that there's a difference between trauma-informed care and trauma-based care. Trauma-informed care is an approach, and that is a system-wide approach that ensures services are delivered in ways that recognize the impact of trauma and prevents re-traumatization for clients. Whereas trauma-based care refers to targeted clinical interventions, such as in EMDR, prolonged exposure, to directly treat trauma symptoms in individuals diagnosed with trauma-related disorders and PTSD. At the policy level, in the policy context, at the federal level, SAMHSA uses trauma-informed and sets the standard for trauma-informed care and trauma-based care through TIP 57 and also through the 2023 Practical Guide for implementing trauma-informed approaches. These standards, they establish best practices, but they are not legally mandated. At the state level in Pennsylvania, it is encouraged. Trauma-informed and trauma-based and behavioral health care is encouraged, but it is not mandated. In New Jersey, I'm not 100% of this is correct, you guys can let me know. But New Jersey trauma-informed care is still pending. And through Senate Bill 3297, and the state is moving forward with making TIC a legal requirement across mental health and social service systems. Slide. And so what is TIC? It is the gold standard in the US, and there's 6 key principles. They're right there: safety, trustworthy, peer support, collaboration, empowerment, and cultural, historical, and gender issues. 4 R's, I'm sorry. Realize, recognize, respond, resist. And these are the basis of trauma-informed care. Slide. Trauma-based care refers to evidence-based, trauma-specific treatments. SAMHSA does not designate one as more superior than the other. We briefly mentioned these already. Prolonged exposure with SUD, CBT, cognitive processing therapy, EMDR, and seeking safety are examples of these approaches. Slide. So going back to the study, where the results were that a higher trauma score increases the risk of developing an OUD disorder, the racial disparities that we found, and then the unexpected finding of no differences in PTSD diagnosis between the groups. Next slide. So now let's look at some ways we can address those findings from the study using trauma-informed and trauma-based care. So up at the top, based on the study, we found that OUD clients do have higher trauma scores. And so the first thing we need to do to address that is to identify these folks who have a trauma history, document past and current PTSD, as well as ensure that people that we accurately diagnose new cases of PTSD. And also, lastly, institute culturally tailored trauma interventions. So how do we identify these people? Screening. One thing we can do is universal screening in all clients in SUD treatment settings. This is a trauma-informed care system-wide approach. If we find that someone screens positive for trauma history, the next step would be a trauma-based approach, which would be a warm handoff to a clinician who can diagnose. Once the diagnosis is made, then we will move to the next level, which would be interdisciplinary care roles. And this would be having them diagnosed by a clinician if they do or do not have PTSD. After that would be to refer for trauma-based treatment and integrate the treatment into their SUD care, OUD SUD care. So both of these approaches use trauma-based within trauma-informed care. And lastly, how do we address the disparities that we find? Integrate care and equity. And these are recommendations at the federal level. And system-wide, a trauma informed care approach would be to develop referral pathways that address the inequities with workflows to make sure that we are targeting underserved populations. Another approach we could use to close the equity gap would be to provide culturally responsive care, as well as partner with community organizations who help to meet the needs of the target populations we're trying to provide care to. A third thing we could do would be to track the screening and diagnosis and treatment metrics that we have in our organization by race and ethnicity to ensure that we're meeting these diversity standards. Next slide. This is a brief slide just to kind of summarize everything together, how we can implement um, all the things that we've learned, including the results of the study, into practice. And the first step in the first box simply states that we need to screen universally. The second step would be to diagnose by a qualified clinician. Um, the third step would be to integrate culturally informed trauma-based strategies into SUD or OUD care, as well as address the referral pathways to ensure that we are um, equitably providing services to all communities. That completes my presentation for today. The last slide is the references. And thank you for your time, Angela.
Thanks, Dr. Jeffries. That was a lot of information, and I know we have some questions in the chat about some of the specific information that you shared, but we'll get to that after our next presentation. So please hold tight for a minute. And now I will welcome Morgan Thompson to speak with us. So welcome, Morgan. Thank you.
Thank you so much. Good morning, everyone. It's a real pleasure to be here with you. Dr. Jeffries, thank you so much for that wonderful presentation, really grounding us in the research and the data and the best practices as it relates to addressing trauma in the clinical setting. I'm going to be speaking more from the lens of lived experience, as well as someone who works in a non-clinical capacity with peer recovery support services. So again, my name is Morgan Thompson. I'm a person in long-term recovery from an opioid use disorder. On July 20th of this year, I celebrated 16 years of continuous recovery. And I always take every opportunity to share that about myself because I think it's so important for others who are in the struggle to hear that recovery is possible. Um, I am someone who has experienced trauma, and I just want to talk a little bit about what that means for me. So I grew up in a household, a multi-generational household that was full of love, but where many of my caretakers and the adults in my life were struggling with their own substance use challenges, with mental health challenges, and that created some instability and some traumatic experiences in my early childhood to the point that when I was just 11 or 12 years old, some of the um, symptoms of trauma were really showing up. And I was engaged in behaviors like self-harm. I was having thoughts of um, worthlessness, thoughts that perhaps I didn't want to live. I was really, really struggling in my very early sort of puberty age. And at that time, turned to substances and began using substances on a pretty regular basis. And it immediately gave me the relief that I was looking for. You can go to the next slide. Dr. Jeffries spoke about self-medicating. This is from the National Council on Mental Wellbeing. And what I like about this graphic is that it really breaks down what we mean when we talk about self-medicating. What did substances give me that I was looking for in terms of escaping the feelings and the symptoms that trauma caused for me? It certainly helped me to not live in those intrusive thoughts. It helped me to manage the feelings. There was also a part of it here where it talks about creating alignment. I felt that the things that had happened to me were my fault, that I somehow deserved the things that had happened to me, and that it was about who I was as a person, and there was a shame about who I was that just seemed to align with someone who would use substances, and the ideas that I had gotten about what that meant. So just kind of aligning my self-concept. It looks different for every person. People experience different types of trauma and it manifests in their lives in different ways. But I really identify with so much of what, the National Council sort of summarizes here about, what do we mean when we say we're self-medicating? The other thing I want to say is that recovery gives us the opportunity to have all of these things too, and to find this relief in healthier ways. So my addiction started very young, but my recovery also started, gratefully, very young. I entered recovery at the age of 18. I was able to access evidence-based treatment. And right from the start, I had some really incredible counselors in my treatment programs who helped me to just begin the process of starting to look at the trauma that I had experienced. And I wouldn't have called it that at the time. I was definitely someone who, thought trauma was something very particular. And because that's not exactly what I had experienced, I thought that wasn't what it was, right? Some of the sort of rationalization that we do. So from the start, I had clinical support. I had really well-trained counselors. Um, and then, very importantly, as I transitioned out of formal treatment services, I was able to enter into a supportive community of recovery. And that was both, sort of informal mutual aid meetings in the community. But very importantly for me, I made the decision to go back to college. I had actually dropped out of college twice in my addiction. And I returned to Rutgers University when I had just a few months out of treatment. And I was able to be in a community of support with people who, like me, were students in recovery. I had a safe, supportive environment to live in on campus, and was able to, find again, a community of support where I was able to work on my education and also continue to be a part of support groups, meet with a counselor on campus, and continue to just very gradually, slowly but surely, work through some of this trauma, work through the self-concept and how the trauma I experienced had distorted my concept of myself. You can go to the next slide. So, so I was in an environment that was trauma informed all throughout my clinical and non-clinical recovery trajectory. And what I found was in the 12-step community and the sort of the non-clinical, non-structured recovery community, we would talk about trauma, but not directly. And what I heard were things like, there are people who have really bad things happen to them, worse than the things that have happened to you, who never pick up drugs. They never develop an addiction. And there are people who, um, have not experienced the things you've experienced, who haven't experienced, significant trauma, who do become, who do develop substance use disorders. And these were some of the things I heard. And I think what I heard at that time was how I interpreted those statements was you don't use what happened to you as an excuse to keep going with your drug use, which was helpful to a certain extent, but over time, and as I continued to be able to talk more freely and to learn more about what people meant when they said those things, I understood that what they were really telling me is that my trauma does not have to define me if I'm willing to face it, if I'm willing to access supports and resources, and if I'm willing to, put some work into healing from the trauma so that I can live a thriving life. And so that was only possible for me because I was in these environments that were trauma informed, that understood that if you're working with a population of people who have experienced substance use disorder, whether they're in recovery or not, whether they're seeking recovery or not, we have to take that approach that they most likely have experienced some level of trauma, if not significant trauma, and that's going to impact whether and how they're willing to engage in services. We also have to understand that it's likely that there's trauma in their family history. I work in a non-clinical peer support environment. Um, on my team, there are close to 25 peer recovery specialists and other people in recovery who don't work in peer roles. Something that I'm really proud of that we keep in mind as an organization is that our staff, and not just the ones in recovery, but it's more likely, to the research we just heard, that there's a likelihood that they've experienced trauma. And so we want to make sure that we're trauma informed in all aspects of how we deliver services and in the workplace. And I don't think that's limited to just workplaces that are focused on recovery and substance use. That, that's really every workplace should be trauma informed. And I think we're gradually starting to have a broader appreciation of just how widespread trauma is for everyone and starting to think about that. Um, but, everything about the environment that we put forth for people to access services should be taking trauma into account. Everything about how we, implement policies and procedures so that we don't re-traumatize people as they're trying to engage. I personally have not experienced this, but I've heard so many people talk about how challenging it can be to have to go to so many different places to get different pieces of the help that they need and have to retell their story of their trauma over and over and over again to someone they just met just to be able to qualify for services. I mean, you can see how that would be, painful and unnecessary and inappropriate. And so, part of what we can do as a field, as folks working in different ways to help people, find and sustain recovery, is to just work more effectively and in better coordination with one another to create a trauma-informed, recovery-oriented system of care here in New Jersey and beyond. You can go to the next slide. There is a lot of overlap between the principles of recovery and trauma-informed principles. And some of the things I want to really highlight are that it's driven by the person. That, when I am engaging in trauma recovery, I need to be leading the charge in my own recovery process. That, the folks who are there to help me along the way are not dictating to me what I do and don't need to do in order to recover. That is, I think, a shift in how addiction treatment has been approached, and we're still working to get there fully. But the peer movement has been tremendous in really advocating for that person first approach. And peer support itself is both a trauma-informed principle and a recovery principle, that lived experience matters. And I have to say that in my own recovery journey, 16 years later, that I can use my lived experience to help others has been such a piece of the healing of my own trauma and making sense. It talked earlier about making sense of the identity and, reconciling that with the trauma we experienced. I know now today that despite what I experienced, I can use my lived experience to help others. We build on people's strengths. We don't just focus on what's wrong, we focus on what's right with people and use that as the jumping off point. And that's, again, something that I really experienced throughout my treatment. People didn't use the fact that I was young as a reason to disqualify me. No one ever said anything to me like, you hear people joke, I spilled more than you used. No one ever said that to me. People took me seriously. People saw my youth as an asset and built on it. And we have to acknowledge past harms. There is a lot that we did wrong for decades in how we addressed addiction, a big piece of it being that we didn't acknowledge trauma. And so the field itself is growing and evolving and getting better and becoming more effective. But we have to acknowledge that there are people who we're asking to engage in services today who 20, 30 years ago were in treatment environments that were not trauma informed and that caused them harm. And so it's going to take time to rebuild those bridges and to help engage people. And you can go to the next slide. I know I'm getting close to time. I just want to speak quickly about prevention. I spoke at the beginning about my home life growing up and that I did experience trauma. I didn't even touch on the trauma I experienced in my addiction, and that, there was a great deal of, trauma that came from the lifestyle of, running away from home and being in dangerous situations and losing people to addiction. But, what I want to say about my childhood is that despite the fact that there was trauma, there was also, as I started with, so much love. And that while we can't always prevent the traumas that occur, we can build resilience and protective factors. Um, Dr. Jeffrey spoke about ACEs. I also like to speak about PACEs, protective and compensatory childhood experiences, and that's something that is within our control to put forth resources and services that build those protective factors and resiliency. There are incredible programs across the state of New Jersey, like family success centers, prevention programs in the schools that help young people learn, social and emotional literacy to be able to have healthy, supportive relationships that teach parents, how to, be present with their children in more effective ways. These prevention resources, um, even if they don't necessarily stop someone from ever using substances, right? If someone has, like myself, does use substances, but had all these protective factors in addition to the risk factors, it increases the likelihood that the interventions that come later are going to work, just like mine did. And so I'm always a proponent that we should really be doing everything we can from a prevention lens to make sure children have the best possible start. And so think about the children that are in your lives. I'm the mother of a 5-year-old. I've had younger siblings. We all have an opportunity to build those protective factors for the young people in our lives, and to support individuals in the recovery journey. So much of what still needs to change is around, as Dr. Jeffrey said, policies and laws and inequities that exist. We have a lot of work to do to build a true trauma-informed system. And I think the more people are willing to share their stories like I'm doing, the more we'll be able to move that forward because it is possible. I think my story is a testament to what can work when the right supports are present. And my story is not a common story. So let's all work together to try and make that more and more a common story. That's all I have. Thank you.
Thanks, Morgan. Thanks for sharing so much of yourself and your story and the impact that has, as we know, the ripple effect, but also for sharing so many of those strategies and best practices that we can put into effect. It goes hand in hand, really, with what Dr. Jeffrey spoke about. So I know we have a few questions, some time for a few questions. So let me talk to you first, Dr. Jeffries. You talk about trauma and the studies that you were reviewing. Can you talk a little bit more about those? Were you talking more about individualized trauma or collective trauma? Can you just give some additional? You're just muted still, Dr. Jeffries.
Sorry about that.
That's
I
okay.
certainly can. In the definitions, we talked about that it just takes a trauma exposure from any type of category. In the study, we were specifically talking about trauma exposures as defined by the LEC5 tool. And the types of traumas that are listed on the tool are natural disasters, fires or explosions, serious accidents, there's sexual trauma, um, unwanted or uncomfortable sexual experience, combat, captivity, even a life-threatening illness or injury can be considered a trauma. So there's 16 different types of trauma listed on the LEC file.
Oh, thanks, Dr. Jeffries. And Morgan, anything you wanted to jump in on that? If someone who just doesn't have any experience with trauma and is just looking for any kind of information on how they would identify. Curious what the spectrum of trauma is.
So, well, I think Dr. Jeffries mentioned some really great screening tools. There are a couple of books that speak specifically to the relationship between trauma and substance use disorder that I think are really well done, and some that I haven't read, but I'll just, mention the ones I have read. In the Realm of Hungry Ghosts by Gabor Mate, is about his work in a methadone clinic up in Canada, and tells some really powerful vignettes about the range of traumatic experiences that his patients have had and how he worked with them with those experiences. And then Chasing the Scream by Johann Hari. Probably many of you have heard his TED Talk, The Opposite of Addiction is Connection. I think that is a very telling narrative about the traumatic experiences of folks with substance use challenges as well.
Thanks. And I know, right, when we look at the lifespan, trauma can impact from childhood all the way up until adulthood. And so the information on the screen, just so everyone is aware, not to jump into the Q&A with with this, but since it's on the screen, there's information on an upcoming um, summit that's going to be held in Atlantic City, New Jersey at the end of this month, that talks about healthy aging. And one of the panelists is going to talk about mental health and dealing with that and what that means. And so, if anyone's interested, the information is on there. And I know we have a poll that I believe just popped up as well. So we appreciate your feedback on this as we continue to discuss this topic. But going back to the questions that we had, how can a parent help identify trauma in their child? I know you both addressed ACEs, and parents hear that, I know, and think, well, what does that mean for my child? How can they identify it, and what are some steps once they have? And Dr. Jeffries, we'll go to you first on that, and then Morgan will follow up with you.
Well, identification is a key piece, and I would say any change in behavior in your child should be investigated for possible trauma occurrence. Um, Making sure you have a close relationship so that the communication is open and honest. And once you identify that there has been a trauma, bullying in childhood can also be rather traumatic. And depending on what the type of trauma is, to move forward with the appropriate steps to address it.
No, absolutely. And Morgan, any thoughts?
I would just add that, when I think about as a parent and also having been a child and what I needed from my parents, it really starts with being that safe person, being someone who's not going to be reactive to the things I share, someone who I can, and again, as a parent, someone who my child can speak to about anything, and that can be very difficult. So, the more we can foster that open communication, and be able to hear things that concern us without having a strong, visible reaction, because that could deter the child from being open with us in the future, that we're able to take the information, reach out to the resources at our disposal. And again, I want to reiterate, family success centers, regional prevention coalitions, mental health counselors in the community, schools. There are so many resources if we're willing to be a little bit vulnerable, talk about what's going on, and allow those folks to help navigate us to the right place. A lot of times these conversations can start in the pediatrician's office. They're more and more knowledgeable about mental health, about trauma. Oh, and someone just chimed in as a pediatrician. I don't know what they said. I only saw the first. But yes, again, I think we're just getting better as a society, of creating those entry points to get people connected to the right help.
No, I think that's absolutely correct. So thank you both for sharing that. Thank you both for being with us today. We're coming to the end of our time. I want to thank all of our attendees as well for joining us. But I wanted to go to both of you again for one final thought, one final piece of information you hope stays with our attendees today. So Dr. Jeffries, I'll go to you first.
I'm sorry, you asked for one final thought?
Yes, just one final thought to leave us with today.
The importance of identifying a trauma history, trauma occurrence, and taking the appropriate steps. And then also the importance of providing the care in a culturally sensitive manner.
Absolutely. Thank you. And Morgan?
There's a lot in the world to be discouraged about, right? But and we all hear the expression hurt people, but also healed people heal people. And so the more we can invest in our own well-being and healing, the better we can show up for the people in our lives who may be struggling. So I just want to encourage everyone to practice their own self-care and to really make that a priority.
Thanks. I think that's a great note to end on. So thank you, Morgan. And so important, I think, for all of you again for being with us as we address this topic, right? I think it helps break down the stigma of these conversations and people who share stories like Morgan does or share the facts and the information like Dr. Jeffries really help us to move forward. So thank you again for all of us, all of you for joining us. Thank you for our expert speakers. Information on continuing education credits is on your screen right now. There's also information next month is Knockout Opioid Abuse Day in New Jersey, and we're so excited to have Dr. Andrew Kolodny, who's going to be speaking for us on that day about evaluating recent progress to address the opiate epidemic. We know we're seeing a number of overdoses go down, but where are we with emerging trends and how far have we come and where do we still need to go? So those are the conversations we're going to be having next month. I hope you can join us on Thursday, October 9th, and wishing everyone a wonderful day, a day where we all take a moment for a little bit of self-care as Morgan suggested. And just again, thank you and have a good day, everyone.